This is LPI on a very thick iris, and you can see as it begins, just starting to make some work through that iris.
And the reason for that is that in a regular, let's say a blue iris, the iris is so thin that usually YAG by itself will be able to get through. In a thicker iris, you would need a lot of shots, which I sadly still have to do here to get through. So I tend to do argon laser to thin the iris first before I get all the way in and open up the iridotomy with a YAG. However, you can still get bleeding and still a lot of pigment. And the other benefit of argon is officially that it can cauterize some of those vessels to decrease the risk of bleeding. Here you see some opening of the iris already. This probably is all the way through. It looks darker. And one way that I check to see if it's patent is I don't like retroillumination, but during the procedure, if the patient can appreciate these dots, meaning they can literally see them, then I know that I have an opening, because these dots do not appear until the opening is all the way through and the laser shines on the retina.
And I remember that's how you ended this laser case, was by asking the patient, do you see those red lights? And when she said she did, we knew that it was patent and all the way through. This patient did have a pressure increase. Pressure went up to 30 millimeters of mercury right after LPI. 2 days follow-up after the patient was on COSOPs, checked the pressure, was down to 9. But you can see the appearance 2 day post-op. You can still appreciate that narrowness of the angle and the shallowness of the anterior chamber. But now with the LPI, which you can see right there in that video at the end, this is a fully patent LPI, and you can actually, with transillumination, see that light passing through the iris. These are the anterior segment OCTs, indicating in the temporal angle 21 degrees, nasal angle about 19 degrees, measured with the calipers on anterior segment OCT. But a good reminder that any normal patient has vasculature through the iris, and a lighter blue eye, you can actually visualize that very nicely.
Those vessels have a lot of blood, so the blood flow that you saw, it's like a gush. You see almost a waterfall of blood coming out when you hit that vessel. Hence, again, argon helps, and I try to use argon even in blue iris to avoid some of those vessels and maybe close them off.
And one more look at that. If you hit just the right spot, that's the blood that you can get from the iris vasculature.
And the pigment in blood is the reason for the pressure increase, because it clogs the trabecular meshwork. In somebody who's narrow angles, that meshwork can be slightly affected already by the narrowness because the iris rubs against the meshwork. So patients like this, that is the time when I'm most concerned about a pressure spike after surgery. Obviously, we have given the patient aproclonidine before surgery to avoid this. But the pigment together with the blood can clog everything else up in an already compromised trabecular meshwork and lead to a pressure increase. The highest thing I've seen was 50.